And welcome everyone. What an honor to participate in this conversation. I just wish that it was in person because I would have loved to have a chance to meet you, to celebrate the new laboratory facilities, and to really immerse in the incredible science that I know will be discussed. So in just a few minutes, I'm going to talk about the pandemic paradigm and what I think it means, not just for Hilleman, but what it means for all of us as we face the next normal of the world. I hesitate to think about the new normal because it implies some kind of stationary phase of life after the pandemic. But I think what we'll talk about and what I think you'll come to agree with is that we are going to be in the process of adjusting to the next normal on an ongoing basis, just given the incredible world in which we are living. So I'll start with the first pandemic that I experienced 40 years ago as a very young doctor in San Francisco at San Francisco General Hospital. I was one of the junior doctors taking care of the very first AIDS patients at the beginning of that pandemic. And of course, at the beginning, we didn't recognize this was an infectious disease. And we certainly didn't imagine that it would very soon become a global threat, maybe not as transmissible as a respiratory disease, but certainly a disease that affected men and women and children of a range of ages and has some of the same characteristics as the pandemic that we are currently facing. For those of you who don't remember the peak of the HIV pandemic, this picture is a picture of the AIDS quilt that was unfolded in Washington Monument area in Washington, D.C. on the Mall. Each one of those panels was lovingly created by someone who loved a person who had died of AIDS. And this quilt went on forever. It, even to this day, makes me tearful because many of the panels in the quilt are people that I knew and took care of before we had any treatment, and certainly no prospects for really being able to extend people's lives. But I think there's some very important lessons, whether we're talking about a 40-year-old pandemic or the brand new SARS-CoV-2 pandemic that we're challenged with today. And I'll go into those in a bit more detail. I believe that we are basically in a race. On one side, we have the virus, its virulence, and its variants. And from time to time, they race ahead of us, as they did with Delta or with Omicron. On the other side, we have vigilance, all of the non-pharmacologic things that we can do to be safer. We have vaccines, powerful tools. And of course, increasingly, we have antiviral therapies, whether they're immunologic or target the virus itself. So we have new innovations that are helping us catch up and in some cases, we hope, go ahead of where the virus is in the race. Nevertheless, we have had a very terrifying journey for the last 2 years. Today, more than 400 cumulative people have been infected with SARS-CoV-2 that we know of. And that's perhaps an understatement because we know we're lacking testing and diagnosis in many parts of the world. But I think that speaks to the fact that this new virus very rapidly emerged and spread on a global basis. So the first thing we need to really think about is the concept of emergence. Why does this happen? Why did it happen this way? What can we learn from the previous viruses and pathogens that have emerged since AIDS in the last 40 years? And I think we have a lot to say about the process of emergence. And it's important as we think about where Hilleman should be targeting its scientific efforts, targeting the areas of the greatest unmet need, and perhaps the areas most vulnerable to the next emergence. That's something we need to keep in the back of our mind. This is just one slide that illustrates the many pathogens, mainly viruses, but sometimes parasites, sometimes bacteria with new resistance factors just a picture of the emergence of infectious diseases on a global basis. And you can see that some of these are brand new. They're organisms that we did not recognize as human pathogens, and others are pathogens that periodically develop a new trick of virulence or develop a new resistance factor and reappear, causing harm to humans either locally or regionally. So it's a complicated picture, and it's only going to get more complicated because I think some of the factors that encourage emergence are accelerating and expanding on a global basis. One of the things that many of the new viral emergence have in common is, of course, they're zoonotic. They're spillovers from animals. And this, again, is just a cartoon illustrating some of them. But I think it's important to recognize that the intermediate hosts or the vectors of transmission and emergence are complex, not entirely predictable, but these animals are very poorly studied. And usually the people who are studying the animal epidemiology are not necessarily talking to the people who are studying the human biology. So I have become a huge champion of the One Health concept, which is we need to look at humans, animals, and our ecology as a system and really understand how the flow of pathogens and interactions influence emergence. In this particular cartoon, you notice that all of the arrows are pointing toward people, but we know this is artificial because even in SARS-CoV-2, we have many examples where the human SARS-CoV-2 virus has gone in the opposite direction, infecting ferrets, minks, cats, primates, deer, in the United States at least. So we see that the movement of pathogens is not necessarily from animal to humans. It can move in the opposite direction as well. And that's why we need to have a One Health mentality when we think about these challenges. So the forces of emergence are fairly obvious. One of them, of course, is urbanization. The incredible density of people, for example, in Western Africa or Southeast Asia, where you have more and more people crowded into areas that used to be occupied by animals and vectors, now are overrun with people. And the red line here shows that this trend is going to continue to escalate for this foreseeable future. Of course, incursion, meaning people moving into animal territories or animals moving into human territories, is something that is also accelerated by social phenomenon like ecotourism. This little monkey is a vervet monkey that I personally encountered in Zambia. And you can see on the right-hand side the consequences of that encounter when that monkey bit my leg. And naturally, I was very concerned about rabies. So I needed to get consultation and concerned about whether I was protected from rabies. And second, of course, just bacterial infections from those teeth, which are not particularly clean. But as we look at what's happening to travelers and tourists, we are increasingly seeing these opportunities. Tourists in a cave developing Marburg infection. People climbing into remote areas and acquiring malaria for the first time. We're really seeing increasing connectivity between humans, animals, and these pathogens. Now, another major factor was, of course, transportation. And we learned this with HIV infection. This family is a family that I met in in Uganda. But their father was a truck driver and probably was infected with HIV as he was moving goods around the Trans-African Highway and enjoying sexual encounters along the way, which was a major force in the early days of HIV for the transcontinental spread out of villages into new villages and new territories in the country. And when you think about the world today and the development of new land transportation pathways, the transcontinental highway in South America, the incredible explosion of infrastructure development in Asia, the Belt and Road Initiative that China is developing to increase not just land transportation, but maritime and air transportation, just building more and more connectivity in areas that were previously geographically fairly remote. We also see an incredible development of air transportation. Obviously, the last 2 years are an exception because of the pandemic, but basically we are seeing an increasing number of people who are traveling and an increasing number of trips. But what's not shown here is now the increased reach of where people are traveling into, again, places that were previously remote and privileged from a human connectivity perspective. And these are not just isolated lucky travelers. These are mass numbers of people crowded together. So it's not just the risk at the destination, it's also the risk in transit or upon arrival that increases the opportunity for person to person or human to animal transmission. Now, on an even more sober note, we have to think about the people who are moving without intent, meaning the forcibly displaced people in the world because of conflict, social strife, or in many cases, humanitarian catastrophes such as hurricanes, etc. In 2020, 82 million people around the world were forcibly displaced for various reasons. And of course, these people are often not housed in sanitary conditions. They're crowded together, they lack running water, sanitary facilities, and the environment is, of course, highly vulnerable for bacterial disease spread, vector-borne diseases, and certainly respiratory infections. And finally, just to say the obvious that all of this is exacerbated by climate change and the various impacts that climate change has on human health. We don't have time to talk about these today. And I think we're going to likely see some pressure for new things to emerge, and possibly in some areas less pressure for emergence of certain other kinds of pathogens. But it's definitely a disruptor of the normal ecosystem, and so a factor that will continue to promote and support viral emergence. So let's take a look at this in the context then of SARS-CoV-2. This virus has now affected more than 400 million people that we know of around the world and has caused almost 6 million deaths. That's phenomenal. The fact that we've been able to administer more than 10 billion doses of vaccines, almost 1 million in the last month, is, of course, almost unimaginable a year ago, but is by no means creating that network of protection that we need to really contain this pandemic for the reasons that we will come to over and over again. That is because this vaccine and all of the other interventions are unequally distributed. If you look over here on the right, there's another story being told here. It's kind of the interplay between virus variants emerging and vigilance coming and going among the people who are affected. The Omicron spike is pretty obvious here in terms of cases. The death spike from Omicron is not quite as prominent, but as of, I think, last week, the number of people who've died globally from Omicron exceeds the number of people who died from Delta infection, kind of showing us that volume of spread is important, even if virulence is less important. And we are not seeing a continued uptick in vaccine doses, even though a significant proportion of the world lacks access to vaccination today. So let's talk a little bit more about this concept of virulence and variants, because I think this has been a characteristic of at least the single-stranded RNA viruses that have emerged. And I'll speak of HIV infection, hepatitis C infection, influenza infection, and of course now the SARS-CoV-2 infection. We have so far, according to WHO, 5 variants of concern. You're familiar with these, so I won't go into them. And I think we like to look at this bottom right-hand corner and say, well, thank goodness, now we're finally seeing reduced virulence, less severe disease. This is what we're hoping for as the virus adapts and adjusts to the human condition. But I think we're a long way from being confident that that's the future of SARS-CoV-2, especially given that so much of the world is unvaccinated. So some humility in our prediction about where the pandemic is going to go is in order in my mind. And I am not going to be lulled into a false sense of security that it's over. I hope that vaccine will curtail the kind of surge that we have been seeing, but until the vaccine is everywhere, there is vulnerability for increasing virulence to emerge. I don't think I can take time to talk a little bit about the biology of variants, and I hope you have a chance to do that. But I would just refer you, if you can only read one thing, to read this article, because it's just a wonderful discussion of how SARS-CoV-2 works, why it's different. There's this video is actually an animation you can see online. And one of the amazing things about SARS is those spike proteins on the surface are not static like we tend to think of most virus proteins on the surface being relatively stable in their position. The SARS spike protein wobbles around. And that means that it has perhaps more opportunities to bind, kind of seeking a receptor, and so on and so forth. But it has many other tricks. And one of them is both a very efficient mechanism of docking on the host cell and more or less injecting its RNA into the cell to initiate replication, but also it takes advantage of a bypass track, particularly the Delta variant, that allows it to have an even better chance of escaping immune surveillance. And in the case of Delta, the impact of that is, as we know, much faster and efficient cellular entry. But also in the final stage of virus release, Delta has another adaptation which allows it to cleave the furin cleavage site, which makes it even more able to get into the next cell faster and bypass immune surveillance. So very rapid evolution of a number of tricks that allows the virus to escape the immune surveillance, whether that's from prior infection or from vaccines, and probably helps explain why vaccines are not sterilizing. You can still get infected because if you're exposed to a very large amount of virus, it enters cells so quickly that your immune system is not able to ramp up and fight it off. But when it finds out it's there, it is able to help prevent hospitalization and death. And that's a good thing for a vaccine to be able to do, as you know. Now let's move to the other side of the race very quickly, just talk about vigilance, because I think one of the fascinating things about this pandemic is that we've actually proven that vigilance works. And by vigilance, I mean non-pharmacologic interventions like social distancing, staying home, quarantine, isolation, masking, hygiene, etc. And I think we all knew from a common sense perspective that that would be the case, but we had really not seen population level evidence for it in a very direct way. To me, the biggest proof of the value of vigilance is the fact that we went a year without an influenza pandemic. Basically, we did not see influenza, seasonal influenza in 2021. And that to me suggests that whatever we were doing, it was effective for the first time in probably since before 1918, at least, that we did not see the usual seasonal appearance and disappearance of influenza. And there are many other pieces of data to show that vigilance works. But I think the one concept that has been the most helpful is helping people realize that it's like a layered of Swiss cheese, that each individual element of this, not so helpful, because there are gaps and holes in them. But when you stack them all up, you do really create an effective barrier to transmission. And that probably is what accounts for the flattening of the curve that occurred when we were able to implement many of these things as a social requirement, or at least a social intent. And we had fairly good societal adherence. Unfortunately, because this is an epidemic or a pandemic that is not just a health crisis, but is also an economic crisis and has created geopolitical crises in many areas, it's very difficult to sustain that level of vigilance for any period of time. because people can't afford to. They need to be able to work, to leave their homes, to educate their children, and so on and so forth. And so the durability of vigilance as a strategy, we're learning, is relatively short-lived, and you pay a huge political price for trying to extend it to the point where it would continue to be relevant. And that's why vaccines have been so important, albeit so maldistributed on a global basis. I think scientists at Hilleman know this probably better than most people, but on the left-hand side of the graph, just looking at how long it took from knowing that a pathogen caused a disease to the point in time when we had a vaccine for that disease. And mind you, we still don't have a vaccine for HIV infection, and that emerged 40 years ago. But really looking at these timelines, and then at the very bottom of the stack, seeing the tiny little time difference between recognizing the emergence of SARS and having effective vaccines available, at least on emergency authorization. And on the right is the Pfizer timeline of how rapidly they were able to move this product with BioNTech and many, many, many other collaborators through the process of clinical trials. And again, we don't have time to go into the details here, but I think one of the most important innovations isn't mRNA vaccines, which fortunately have been worked on for a long time for other pathogens. But I think it's the fact that there was a great deal of innovation, not just at Pfizer, but at the FDA and in active, the vaccine collaboration, warp speed, COVAX, to really understand that we could accelerate the regulatory sort of backroom processes and do many of the non-essential clinical development steps in parallel rather than stacking them forward over longer periods of time. So I hope that some of those innovations will help Hilleman going forward, but certainly we've learned that we can do things a lot faster than we ever imagined. Unfortunately, this is the slide that we should all be ashamed about, because this is the slide that shows the per capita coverage of vaccine around the world. And of course, it's a picture of profound global health disparities. And there are lots of reasons for this. One of them is the number of available doses. One of them is lack of systems to test and diagnose and manage the pandemic, let alone administer vaccines to adults in countries that have never had an adult immunization program. But mostly it's political decision-making and the judgments of the have countries versus the have not countries about how we are or are not sharing the world together, and what we can learn and do differently about this as we go forward. Because I fear if this graph doesn't change very much, we'll be back next year talking about this same thing at the Hilleman scientific meeting. A couple of words on viral therapeutics, because we have made some progress in this regard as well. But I think unlike vaccines, where we may be heading into the 2.0 area of vaccine development, we're probably still in the 1.0 era of the therapeutics for COVID. And I say that because even though I work, for Merck, and we have a drug that we know can help prevent hospitalization and death from people who have risk factors for infection, and Pfizer has an oral antiviral that has a very good track record of doing the same thing. These are 1.0 antivirals. This is a single-stranded RNA virus. So we have to be thinking about the 2.0 antivirals. We have to be thinking about immunologics that are more robust to variants. And we have to be prepared for the emergence of antiviral resistance. Of course, that means combination therapies and other strategies to try to improve the ability to reduce the harm, not just before people are really sick, but once they are in the hospital and are suffering the most severe consequences of the disease. So lots of opportunity here. I get hope from this, from the HIV experience, and I'll end on that note in a second, but just to kind of wrap this all up and say, we are in a race. We're running against a really facile enemy here. This virus and its variants and its incredible virulence is formidable. And at the same time, we have a human spirit that has been able to not just protect ourselves and our communities for at least periods of time by doing the right thing and taking the altruistic actions that we need to, but we have created a dozen vaccines in unprecedented time, which really do have an important role to play. We need the next generation of those vaccines as well, but something that we couldn't have dreamt about in 1981 when the AIDS virus emerged. And then, of course, I think we will see some fairly rapid advances in viral therapy because small molecules are easier than large molecules, and immunotherapies are something that we've perfected for other conditions. But when you look at this picture and you see the virus, talk about the variants, the vaccines, the vigilance measures, and then just replace your mind of SARS-CoV-2 with HIV. We've got the virus. It's incredibly virulent. It has incredible tricks. It has variants, quasi-species in any individual person. We know that vigilance, non-pharmacologic measures can significantly reduce risk, but we also know they're very hard to implement over long periods of time, especially in young sexually active people or people who use injection drugs. We haven't found a vaccine for this particular pathogen yet. I'm not giving up, but maybe some of the platform work that has been evolved for SARS-CoV-2 can be adapted to improve the prospects for, if not a preventative HIV vaccine, a therapeutic HIV vaccine. But we've certainly excelled in treatment. The medicine chest is almost unimaginable to me. It's so complicated now to treat HIV that I, who started out as an HIV doctor, will not do it anymore because I don't feel like I can master the pharmacology of all the different drugs and drug choices that are available on the market. But for both of these pathogens, whether we're talking about HIV 40 years ago or SARS-CoV-2 in 2022, the overarching picture that all of us have to contend with is that of health disparities, the incredibly unequal access that people have to these promising interventions, whether we're talking about vigilance, treatment, or vaccines. And I think that's one of the reasons why I feel so committed to the spirit of the Hilleman Laboratories and what caused us to come together with Wellcome Trust to try to do more and do it faster to make vaccines available to the people who needed them the most. And I hope some of that spirit of the Hilleman can sort of percolate through our society and remind us that we're only safe until everyone is safe. So I'll stop here and we can have some questions and answers. Thank you.
Right, thank you. Thank you, Dr. Gerberding, for your valuable insights. I'd like to give everybody a reminder for those who are sitting in the ballroom. You may actually post questions via the QR code that is actually located on your name badge, on the other side of the name badge. As for those who are joining us online, you may actually scan the QR code that's showing up on your screen to post your questions. Right, so now we'll move on into the Q&A segment. For audience members, if you have any burning questions, do feel free to post your questions to Dr. Julie. Okay, so we have the first question. What are some of the key challenges in responding to emerging diseases in low and middle income countries? Dr. Julie?
Well, every dimension of the ability to respond is challenging. First and foremost is, of course, anticipation. Where are emergence likely? Where will disease be the most likely to cause significant human infection? But a piece of that is detection, and that means laboratory capability and clinicians who recognize that what they're seeing is something new, or veterinarians who are seeing something and recognizing that it's something new, so that the laboratory tests can be ordered to create the earliest possible warning. So detection is a huge challenge. The second challenge is, of course, the ability to monitor spread, the surveillance tools that are necessary. We've seen tremendous challenges with contact tracing in every country, not just the developing countries, but I think it's especially challenging when you don't have a public health infrastructure and a lot of practice with that particular intervention so that you can effectively introduce quarantine or isolation when it's necessary. And then the third, and I think the biggest challenge we're facing right now, is that we need a test and treat strategy, but we don't have access to reliable testing. We don't have access to reliable therapeutics and health systems that are capable of delivering them. But we learned that lesson with HIV because everyone said, well, there's no way you could introduce highly active antiviral therapy into Africa, for example. And yet PEPFAR has done that, Global Fund has done that, and we've seen a 65% reduction in the incidence of disease in countries that have been participating in those efforts. So I don't want to say that it can't be done, but I think it needs global support, investment, and it needs local leadership and engagement and trust. And right now, trust is probably the hardest barrier to overcome.
Right, thank you, Dr. Julie. Going to the next question. Is Merck or other pharmaceutical companies planning a flu-like COVID-19 vaccine in future, which will be seasonal and changes every year based on tackling the prevailing strain?
Well, one thing I think we can all agree is that we're not going to be able to immunize the world 4 times a year, every year. So if we don't have a vaccine that provides durable protection, we will probably have to find a better 2.0 version going forward. I still think there's a lot of uncertainty about the long-term value of our existing vaccines, not so much in preventing infection, but preventing severe disease and hospitalization. And I would really like to understand the immunologic correlates of protection, but also to have much better data on how long are we protected, even in the context of variants. Having said that, I'm quite concerned that there will be emerging variants that will fully escape from the immune protection layers that we have right now. So we have to be able to exploit the platforms that have been developed, at least temporarily. Down the road, we probably need vaccines that are multivalent, perhaps, that combat more than the spike protein of the virus. And we need to make sure that we're getting a full repertoire of cell-mediated immune response so that we have the best possible chance of durable immunity over the long run. So much to know and learn and study, and then much to do and try and experiment.
Right, thank you. And looking at time, we'll have one last question. Why do you think it was particularly difficult for low and middle income countries to procure and secure COVID-19 vaccines?
This is an answer that has many answers because it's not one size fits all. There are many different issues that varies from one country to another. But I could summarize the main themes of this. So first and foremost was supply, especially early on. There simply was not enough vaccine made available. And there were some disappointments in supply that was promised and then couldn't be delivered for various reasons. So that's a failure on the part of the global community. And I think all of us in the developed world own that. And that's something that I hope we can work harder as multilateral organizations to find better solutions to that. So it's not anything to be proud of, that's for sure. But the second piece of it is the other side of the coin, and that is that at the local government level, many countries have never vaccinated, for example, adults. So there are no systems for doing that. There are no cold chain storage, supply chain issues. The financing is challenging to get off the ground, to get started. And then the last inch is the hardest because the concept of an emergency use authorization is experimental in most people's minds. It doesn't really matter how much confidence we have in the safety and the value after 10 billion doses have been administered. Many people still feel like these vaccines are experimental, and the suspicion and the lack of trust that we see at baseline around immunization or Western medicine in some societies is just confounded by the fear and the panic that a pandemic creates. So many, many barriers, and some of them can be solved structurally, but many of them have to be solved by trusted people on the ground who really can build the infrastructure and the trust necessary to inspire confidence and grounds up immunization programs.
Okay. So we do have one more question from the audience. So the question is vaccine hesitancy a health issue or a social issue?
Yes, it is, of course, both. Thank you. We have to be careful, I would say this candidly to this audience, that we have to be careful that we don't ascribe all failure to be vaccinated to vaccine hesitancy. Because as I just said, it is complicated and we have to provide the support. It's been common, I would say, in my reading of some of the news media to say that, well, the doses are available, but they're going to waste. The people just aren't making good use of the doses that are there. Well, my answer to that, and maybe I'm wearing my CDC hat or my citizen hat, but I think that all the more reason why we need to roll up our sleeves and help all of us, and to not just say, well, too bad, they don't know what to do with it. We've given it to them, but they're not making use of it. I think that is a structural issue, and we need to address that now for this pandemic, but we need to also build more reliability into adult immunization programs going forward. So to me, that's not a hesitancy issue. That's a structural policy kind of societal issue that we need to globally engage in as part of global health security. On the other hand, clearly vaccine hesitancy is a social issue. It's an issue that is accelerated all too often on social media. It's peer-to-peer, and it's a reflection of, I think, the fear and concern that people have, which is very legitimate. It's a pandemic. You should be afraid and worried. But at the same time, a society everywhere, whether we're talking about the US or a country that has much less resource, health literacy, scientific literacy is low. And these are difficult concepts. And if you are frightened and you hear something from someone you do trust, like your neighbor, your friend, or your grandmother, it's very tempting to just say, not doing that. So it's complicated, and it's going to be a hard problem to solve.
Right. Thank you, Dr. Gerberding, for addressing the questions from the audience. Let us give her a round of applause. Thank you.
Thank you. Thank you very much.